Welcome, everybody. It's really a pleasure for me to introduce our Nesbit visiting professor today, Dr. Stephen Nakada. As many of you know, Dr. Nakada is professor and chairman of the Department of Urology at the University of Wisconsin. He's also the David T. Euling Chair of Urology there. He received his medical degree from the University of Rochester, where I had my first job, and completed his residency there also at Strong Memorial Hospital before doing a fellowship at WashU. Thereafter, he moved to the University of Wisconsin in 1995 and subsequently became the inaugural chair of the department in 2001. In 2020, Dr. Nakada was named the chief administrative physician of the entire practice plan at the University of Wisconsin. Dr. Nakada has innumerable awards and prizes, and of course his scholarly achievements I think are well known. But perhaps what he's most well known for is doing the very first hand-assisted laparoscopic nephrectomy, I guess dare say, in the history of man. So that is really an incredible feat. Before Steve kind of comes up here to give his talk, I'd like to bring him up here and ask him, or I think you're mic'd up, yes? To ask him some questions. First, welcome. And the second is, well, what was going through your mind during that first case? Like, how does one prepare for doing something the first of anything?
Yeah, so when I came to Wisconsin, you know, the goal was to bring laparoscopy, or one of the goals. And every case that was sent to me was virtually impossible to do laparoscopically. That was kind of the way it was. And I was sitting in the operating room lounge, and there's a general surgeon who I think used to be now chair at Northwestern, Dave Mavi, and he had this device. And I said, can I use that? What are you using that for? And he said, to do splenectomies laparoscopically, hand assist. And I go, can I do it for kidneys? He goes, sure. I mean, makes sense. So I said, can you just come in and put the device in, and then we'll just do it? And he said, sure. So we got it in, and you know, we identified quickly that this was a very reasonable way to do the operation. So we did a chronically infected kidney. You know, the case report reveals the details.
Yeah, left or right?
Right, okay. The right side. And then we did a renal mass. And in order to use the hand assist device, I had to be a member of the Southern Surgical Society, which I wasn't, of course. So I signed up, and then quickly 2 nephrectomies appeared on the registry. And actually Howard Winfield, a well-known laparoscopist, called me and said, are these your cases? And I go, yeah. And he said, are you going to report it? And I go, I was going to wait and do a couple more. He goes, if you don't report it, I will. So we reported it, and yeah, the rest is history. You know, Stu Wolf, a former faculty here, he and I taught courses for over a decade. Yeah. And I think a lot of people still use the procedure.
I mean, were you any anxious, nervous, or, I mean, obviously...
Yeah, it's probably more history than you wanted. Sure. I mean, I think at the end of the day, it was you know, I think preparation is the key. Yeah. So we knew exactly what we were doing the first time. And I think also in the early days of laparoscopy, the biggest risk was the stapler. Staple malfunction. Right. And in point of fact, having my hand in there made it easier. Right. And it was very quick to take your fingers and get around the hilum and just fire it. I mean, today, you know, with the 60 millimeter, 80 millimeter stapler, you don't even need to dissect the hilum anymore. Right. So I think that was a big plus. And truthfully, you know, for the audience, laparoscopy did not take off initially because of the risk, and it was too steep of a learning curve. Yeah. And, you know, having a practical approach that more urologists could carry out, you know, is ultimately critical. And a good example is the robotic prostate. Yeah. I mean, Ralph Klayman and Bill Schuessler spent years trying to perfect the laparoscopic prostatectomy, and Harry Turk and Valenciennes, you know, perfected it. But really, this was not exportable. Very few people. Yeah. And I think with Menon and you know, bringing on the robotic approach, you know, that was something everyone could do. Yeah. And I think ultimately we all can't, one person can't take care of all the patients. Yeah. So I think we have to offer something practical.
Cool. Well, what I also failed to mention is, for those of you who don't know, Dr. Nakada will be as president-elect of the AUA as well, in addition to all of his other roles. But with that, thank you for joining us. We look forward to all your talks tomorrow as well. And welcome to the University of Michigan.
Yeah. Thank you, Ganesh.
Thank you.
Well, listen, truly an honor, to be here, and I appreciate the opportunity greatly. You're all very fortunate. You're obviously one of the top, if not the top, urologic institution in the country. I firmly expect to learn more than I teach, but I'll do my best. Can I have my first slide? Oh, I have to do that. All right, so endourology 2023, what's hot and what's not. I'm on X, now it's called, so feel free to comment. I'll answer the DMs later, but anyway, feel free. This is where I come from. We have a very good team as well. We took this picture when Tudor was still with us, but we'll have to fill someone else in for next year. But I also use this slide to say I have no disclosures. One of my favorite sayings is, what I've learned is, you're learning every day. So please consider reevaluating what you do daily, not only in urology, but in your life, because I think it's an enriching truth. So I'll divide the talk into 3 areas: new technology in endourology, surgical procedures in endourology, and then non-surgical approaches to kidney stones. So we'll start with technology. For the older people in the room, what's the movie and who's sitting there? Goldfinger, right, James Bond, the early use of the laser. Anyone know Goldfinger's first name? Yeah, very good. AU, as in gold. Well done. So laser technology 2023, really can I get that video to click? Can you turn that on? Because I would normally do it with the mouse. Okay, don't worry about it. So there's the Moses mode Holmium, which is, at this point, a more efficient, precise approach to breaking up stones with the Holmium laser. We also have the Soltif thulium laser, which has come out more recently, that outperforms Holmium in terms of dusting, retropulsion. It uses smaller fiber, and even most recently, there's something called the Thulio laser, which uses a third wavelength, which is a compromise between the 2 lasers. And I'll try to make a case to you that the Moses mode Holmium is probably the most stable and the laser we know the most about. The Soltif might produce too much heat, and maybe Thulio will be the best of both worlds. We'll see. Ibrahim from New York did the first double-blind, or Montreal rather, did the first double-blind randomized trial comparing just regular and Moses mode Holmium laser, and basically found a 9-minute advantage in terms of time savings with the Moses mode. Really no significant difference in stone free rate. The Moses mode technology is about $25,000 more. The fibers are about $100 more a piece. So we studied this first in a retrospective way. Did the Moses increase efficiency for us? And we looked at 200 cases consecutive, and we compared the 2 and basically found no difference. Aside from learning our complication rates, which we sort of already knew, there are only mild technical benefits. So at this point, we didn't find evidence, at least in a clinical setting, that the Moses was better. But really the question is Holmium with Moses, which is pretty much what everyone uses today, is it as good as the thulium, the new laser? So this trial from European Urology by Ulvik and many of the inventors of the thulium technology did a randomized trial and found a significant advantage to the thulium laser in terms of stone free rate, in terms of time to treatment, and visualization. So this is powerful information. This is well quoted study, as many of the endourologists in the room know. But ultimately, if you read it more closely, they compared the high-level Soltif laser to a low-powered, older version of the Dornier thulium fiber. So, many people felt that maybe this wasn't a fair comparison. So that led Chris Haas, my former fellow, to carry out an RCT, which is published in the Journal of Urology. And we compared the Moses Holmium laser to the thulium, and we did an RCT of 108 patients. And in this study, interestingly, we used time to surgery for the surgery and fragmentation as our main endpoints. And we didn't find a difference. And we looked at stone-free rate, quality of life, which I'll talk about later as a general research topic, and complication rates. We did note a slight improvement in ablation efficiency, actually with holmium with Moses, but not really sure what that means ultimately. Here's some of the data looking at the two, and effectively the good news is they're both very good lasers. I think the procedure is straightforward, since we were talking about, technologies that put skill in everyone's hands. Certainly the latest lasers make stone procedures relatively straightforward today. But either way, no big difference except for perhaps ablation efficiency. We have subsequently done an in vitro comparison, which is soon to come out, and we compared the P120 Moses and the Soltif, and there's beginning evidence that potentially the thulium has higher degrees of temperature, and this could be damaging to the urinary tract in particular. There have been case reports of urinary strictures and renal pelvis damage, particularly when doing longer procedures with larger stones. Pressure has also been a consideration, but temperature is one. And this is an in vitro model we used. The upper tube is a tube that we used to break up stones using the thulium, and the bottom tube was for the holmium. So there's actually also a carbonization effect that we saw with the thulium fiber. So I think there are some concerns potentially with that device. So either way, it's an important area for all of you to consider in any aspect of urology that you're in. And I have sort of some rules of thumb when it comes to new technology. And number one, you have to look at the cost-benefit ratio, and in this case, it's just more cost. Both are expensive, but they're about the same. I think you want a measurable improvement in patient outcome, and you can do this traditionally from an oncologic perspective. Let's say better margins, stone-free rate, continence. You have to, or could have, a better complication profile. And I think the key is does it add to the transferability of skills? Does it make a complex procedure more routine? And those are reasons, I believe, to seek new technology. So when it comes to the Moses versus thulium, we find no difference. HoLEP is facilitated by either device, but typically the Moses device. I'm worried about heat with both, and multi-center studies are underway to really look at many of these questions. So we hope to answer them for you. What's some other technology? The mini PERC technique is something that my colleague Margaret Knadler, is doing for us, and at this stage, it appears to be a good technology. And basically, for the non-endourologist, this is using smaller instrumentation through a small trocar site, and typically, this is a good technique for difficult ureteroscopic cases. The sheath diameter is significantly smaller, but you also have a smaller working channel, but certainly has its advantages, and it's a good approach. Here's an image from one of the ORs looking at using the Cleopatra sheath and a smaller device through a small incision. And just you can see, really, you get a vortex effect, and here you can identify this is likely calcium oxalate dihydrate stone. Some of the work here from here showed that you could identify stone composition just by the video. So here's an example. This is a smaller stone, but you can see this is in a lower pole. It would be a difficult ureteroscopic case. So potentially this can be done very nicely with a mini PERC and good results. There have been some good randomized trials comparing mini versus ureteroscopy, and for mini there is an improved stone-free rate, similar or improved OR time, and similar complication rate. Not sure how much I believe of that, but in the right hands, certainly there's a place for mini PCNL. So I'm sure you're doing it here. Be interested in your thoughts, but certainly it's good to have in the armamentarium. The other question I said immediately is, should we do this for all PERCs? Why not make the sheath smaller? And bottom line, in comparison, it does look better, at least by trials, but from my experience, again, how long you're there makes a difference. And in addition, visualization on a difficult stone, particularly a stag, I don't see a huge benefit. We do like having the mini equipment around because occasionally you can get to some stones that you couldn't otherwise with the standard equipment. And ultimately, of course, like anything else, they'll be ultra mini, and this will be a very small scope. Don't really know. It's doing well in Europe, but don't really know. We haven't used it here, but certainly I suspect there'll be some AUA abstracts on ultra mini PCNL soon. So mini PCNL, in my view, it's sort of iterative improvement. It's more versatile for removing large proximal ureteral stones and some renal stones. It can be applied to some complex anatomy patients, can be done prone or supine, and appears to be comparable. So I think it's something that's worth noting as new technology in our area. This is a different slide, changing topic. This is during COVID, and aside from the infection numbers going up, the WebEx or Zoom numbers went up significantly. You can see 800%, at least at the University of Wisconsin during COVID. I think we all learned very well how to work and work effectively, even using the virtual platform. This is from Tom Chi. In California, they were ready. They had been doing video visits actually pre-COVID, but they had a huge advantage because once COVID started, they had the systems in place. They just had to use it, and you can see how effective that was for them. Eventually we all caught up, and I'm sure here video is a big piece of how you carry out your practice, and particularly in referral center situations, I think this is vital. In our own department at the university, 20% of our visits are telehealth, whereas at our non-university site, that number is much lower. And myself, it's pretty substantive, and I think we have the opportunity to really reach out. It's very difficult for us to see patients one time and get their surgery. It's great to have patients come once just for their surgery instead of multiple times. So I think our reach is much greater. You can see this is kind of how we do it. And you can see there that patient, now it's obviously on one screen, but this guy's in his car. And I have a license in Minnesota and Wisconsin. So occasionally we would have a patient from another state come in to Wisconsin in their car, and then we can do their visit, which I think might be illegal, so don't quote me on that. But basically, we can do their HPI, we can get stone risk factors, we can do most all of it other than meet them and see them and examine them. And certainly we've had a few interesting surprises when we see some of the bigger stone patients actually show up. So we're continuing to work on that. Here's something interesting. This was something we were very hot on at one point, not to coin the talk, these shared medical appointments for 24-hour urine medical stone evaluation. I work with a real savant in the field, Chris Peniston, and we did this thing where we would see 12 patients at once and give them all the information and then assess their knowledge and satisfaction, and it was much higher in both. IPA means individual patient meeting and assessments versus SMA was group assessments. So this was terrific, and we had published it in JU and in JENDO, and this was what we were doing, and then COVID hit, and then we've closed the clinic completely. So, I think there's some great ideas that work, and there's some great ideas that, may not be timely. So what's hot and what's not in technology and endourology 2023? Sure, I mean, laser technology is hot, literally, so I think we're going to have to study that and work on that. I think the mini perk hot, and I think the use of telehealth is critical. I think particularly for referral centers, we're able to have a much better reach to do the complex cases, which is what we need to do. What's not? Group visits for stone prevention, as I said, and too much heat. So to me, telehealth is probably the number one item out of these things in terms of technology. Let's move on to surgical procedures in endourology, what's hot and what's not. So for the non-endourologists in the room, stone disease is about 8% of the population. The lifetime risk is 12% in men, 6% in women. The general age range is 20 to 60, although you see many people over 60. I just think stone recurrence might be lower based on some data that's come out. It's $5 billion annually. There's a very high recurrence rate, and the number of emergency room visits were staggering in 2009, and obviously now it's even much more significant. So it's a big part of what we do. And again, for the non-stone people, shockwave, lithotripsy, small stones, you can use a lot of tools to figure out how low your stone-free rate is going to be. Ureteroscopy is probably, the most common treatment, and PCNL is for bigger stones. But basically, I would say PCNL is how you get rid of the stones, if that's what you really need to do. So if you look at the practice of urology in the United States, this is older data, but the newer data is pretty close. Most urologists that recertify do endoscopic work primarily. The big procedures, you would be surprised at how few practicing urologists do, large numbers of big cases. And if you look at just PCNL as a good measure, back then, the average number of PCNL for recertifying urologists is somewhere between 1 and 0 over a 6-month period. So it's in the hands of a few. I'll show you some data that's more promising in that area. But either way, with stone disease, it's a big part of what the practicing urologist does. So I think it's an important area of learning for them. This is a paper by Chuck Scales that just sort of looked at the HCI database and overall surgical therapy for urolithiasis, in the USA. And basically the learning point here is a lot of shockwave patients required another procedure compared to URS and PCNL. And shockwave lithotripsy was used a lot back then, because even secondary treatments were typically shockwave. This is Canadian data that looked at their surgical stone cases, and that's a national system, so you were in the hands of specialists a lot. The blue line is shockwave, the red line is ureteroscopy, the green line is PCNL. And so in 2004, ureteroscopy exceeded PCNL for procedures. What would you guess that year is in the United States when ureteroscopy exceeded shockwave in the US? Just throw a year out. Okay, 2001, 2010, okay. Okay, nice try. 2017. So this is our Medicare payment data study looking just at Medicare. And these unique NPI numbers, this is in JENDO. And in 2017, the URS volume overtook shockwave in 2017 and became the more dominant of the two treatments. Regional variation was also substantive in this group. Which is maybe a little bit of a surprise, and regions that shifted slower were the east, south, central, mountain, and then eventually western, south, central. So treatment for stone disease, which I've already said is a big part of what practicing urologists do, is pretty different and regionalized. If you look just at the higher stone volume urologists, and that would be just 10 or more as an arbitrary selection, you can see that ureteroscopy gradually increased, and it's still surprisingly late. And these are the volume trends: ureteroscopy only, shockwave only, and then doing both. So, this is later than expected, but either way, I believe these numbers reflect the training, the excellent trainees, and the training that you're all getting so that you're very comfortable managing stones with the scope, and probably is the right way to go. And these are the regional trends that I stated, and again, quite different, and I think that's the take home here. Well, we wanted to look at all of it, so we did a similar type study. We plotted now PCNL, ureteroscopy, and shockwave, and we also looked at population growth, and we based it on what were standard estimates of almost a percentage per year in the US. So this is US and Medicare again. And then the prevalence of stone risk, which was also measurable. And this is what the age range and the frequency pyramids look like from 2013 to 19, which was the study period. And so in 2013, urologists performed 68,000 stone cases in the Medicare database, and you can see 62% were shockwave, 37% ureteroscopy, and only 1% were PCNL. And by 2019, those numbers had changed dramatically. Ureteroscopy was number 1, PCNL was up to 1.4%, and shockwave had gone down. But either way, the utilization of ureteroscopy and PCNL were both up substantively. So we're doing more surgeries and more surgeries than both the increase in population and the change in prevalence of stones, as far as we can tell. So what are the trend results here? Well, shockwave utilization was stable with slow decline after 2015. Urologists performed more ureteroscopy. It more than doubled in this time frame. So obviously, we can talk about why that happened, but it's a big number. And urologists performing PCNL, at least in this data set, increased from 32 to 70. So more urologists are being trained. And again, that's a credit to programs like this, where you train people to be very efficient at doing this procedure, because as we know many times, this is the best approach. So here's 2013 to 2019, and now you have shockwave, ureteroscopy, and PCNL. So actually the growth is greatest in PCNL. Now we have different numbers in the different axes, so you can see the actual numbers are lower, but PCNL is growing, which I think is a positive trend in the United States. And if you compare us again to the Canadian data, you can see that we're late. And there are a lot of good reasons for that probably are worth at some point talking about in the next day and a half. But either way, the numbers are what they are. Our study limitations include Medicare patients only, assumes accurate coding, limited outcomes data or none, includes repeat treatments. We obviously don't know the selection criteria. And we had to use surgical volume minimums to get the data right. So the conclusions of volume of stone surgeries in the US increased by year, greater than the population growth. PCNL has grown in tandem with ureteroscopy, as well as the number of urologists performing these procedures. And shockwave is on the decline in utilization and popularity, at least amongst urologists treating Medicare patients. So, how do I see the current state of the stone field based on, a lot of what I presented? Total cases are on the rise, and there are a lot of reasons for that. Maybe we're treating more residual stones, maybe there's more stone disease, or we're actually treating people and getting to them in time. Hard to know, but it's on the rise. And we should keep an eye for that. I think what this does is make a better case for medical prevention and stone prevention, and I think there's been some excellent work out of this department by Johns Hollingsworth that really showed the relative lack of use by urologists of 24-hour urines. We have seen, and it's just not in this slide deck, in a study we did, that the use of now the 24-hour urine single kit has increased substantively over the last decade, but still a minority of urologists are doing prevention. And there's a case for that, as well as health-related quality of life. Regional variations exist, so this is could be related to climate and diet, but and certainly the worldwide data supports that. But I think it's probably more likely practice patterns and training rather than diet and lifestyle. Good news is more urologists are active in stone procedures, and I also think it's generally good news that ureteroscopy has surpassed SWAL, mostly because the history of the results really have never been what we've wanted unless urologists are highly selective. And finally, PCNL is on the rise. I mean, the stone-free period between treatments is greater, and perhaps that's the reason. And also, there are more skilled endourologists in the US at this time. I think we also are seeing more larger stones, and this is possibly a disparity concern. Access to screening care, follow-up, and preventive strategies continue to lead us to see more patients with staghorn stones. When I first started practice and I was treating staghorn stones, I really felt like I wouldn't see these patients 25 years later. But in point of fact, we see more. So all good food for thought on stone disease. Anyone know what kind of car this is? Any car people in the audience? Okay, it's the Duster. Plymouth Duster. So I'm a Duster. So this is how we do ureteroscopy still. We use the UraSeal, which I think is a great device. I don't have any IP in it, but it allows you to put baskets, lasers with a click of a button. I use a Pathfinder bulb irrigator. I know the endourologists will debate that potentially this is higher pressure and dangerous, and they're probably right, but we've been doing it. The videos could run, but either way, it's a simple device. It's $27, and that's how we create pressure when we need it, and I sort of can control it when I use it. We measured the pressure profiles generated by the different hand control pumps. This was at AUA, and basically the Pathfinder was lower than the BSC single action pump, but certainly the pressures are high enough that it's concerning. So I do think it's a piece of the puzzle, and that and temperature are areas of great study which this institution is very interested in. So I'll be interested in hearing what you all think are the latest. But we continue to use the Pathfinder, but we certainly use it parsimoniously. So we use a wireless technique. So we basically put the wire up, so it's not totally wireless, and then we pass the scope over the wire. We don't use a safety, and we'll go up and treat stones. We'll use a sheath only when we have trouble getting the scope up. We typically dust the stones, and at the end of the procedure, we replace the wire in the case that we leave a stent. You can hit that next thing. That's not a big deal. And that'll just show us putting a wire through and going out. We always try to do a retrograde polygram to get anatomic information and then guarantee safe placement of the stent if we place it, but we do that quite often, I'll admit. So we published this in 2012. Actually, Mike Grasso did the first completely wireless ureteroscopic procedure and published it in 2005. But we just backed it with more cases, and basically our complication rates are very low. I believe in doing less damage to the ureter, so placing a sheath in every case, to me, aside from the cost and the time, can damage the ureter, although I can't prove that. Some urologists would make the case the sheath saves time. I certainly haven't seen that, but this is our approach. Ultimately, we had all these reasons or guidelines because my mentor and others said it's a dangerous technique to treat. But today our guidelines are pretty simple. Renal procedures and ureteral access is straightforward. So we'll do it almost for most cases. And we began to look at our results, and I think I had a fellow who was very good at sort of these different curves for outcomes. And one of the questions that our patients ask the most is, what are the chances I'll need to have this again? And so we embarked on publishing our own work when we were using this approach. So this is the role of residual fragments on the risk of repeat surgery. So what are your chances of needing another ureteroscopy, regardless of whether it's a new stone or a residual stone? This was our stone-free data, which actually mirrors a lot of the published data, even with basketing, but we did not use CT, so it's probably not a completely equivalent data set, and that's another area of discussion. But our residual fragment data looks like this, so the chance of you needing another procedure depended logically on the size of the fragments that were retained or remained immediately after the procedure, from no stone to 1 to 2 millimeter to 3 to 4 to greater than 4. And you can see overall it's about a 20% risk over 8 years that you would get another procedure. But obviously you could also have a new stone. We didn't always know that. The other thing we looked at here was risk factors for repeat surgery, and this pretty much mirrored the Mayo Clinic data in terms of what risks are for stones: diabetes, recurrent UTI, malabsorptive conditions, renal bilateral stones, females, and those less than 60. But in our analysis, in this larger data group, we identified your risk was pretty high if you had 5 to 8 risk factors. And the fewer risk factors you had, the more likely you'd not need a repeat procedure. So you can do a lot of predicting if you just have this information at the time of your history and physical, and that's part of our intake for all new patients. This is just more validation. Stone composition was logical. Calcium oxalate stones we did better with, and cystine stones we did the worst with. And again, that makes sense based on the metabolic factors and in cystine and the composition of the other stones. So this really more validates that what we were looking at was probably accurate. We did eventually look at the lower pole angle. Can you go back one? I think, yeah, thank you. In this same model, and again, the more acute angle was associated with less success. This was an old study because it was used for shockwave lithotripsy, but also we always do a retrograde, and certainly that's a way to predict potential residual stone or recurrent stone. And leads us to want to remove more of the lower pole stones when we can. Shifting gears a little, something we've been doing now, since 2018 is we have the ultra low dose limited renal CT. So, you all do low dose CT, and at the end of the day, in the endourology world, the biggest question is how do you follow people with stones? And, leadership at the Journal of Endourology would say you got to get a CT on everybody, but the cost of a CT is $3,000 to $4,000. Anytime you get in an axial type circular machine, that's what you're going to pay. So do you want to have a CT every year or even every 18 months? One of our leading radiologists, who's a brilliant investigator, said, what test would you want? And I said, I want the CT because I want volume. He goes, how about radiation? I said, well, I kind of care about it, but, it's pretty low anyway. But what I really care about is cost, So if you look at our place, we have developed the limited stone CT, which has a low technical fee because we don't look in the ureter. We just do 3 millimeter collimated shots of the kidney. And so we get rid of a lot of the radiation because we don't cut through the abdomen, because you're doing a lot of looking just for the ureter. And we were able to get that at around $1,000. Renal ultrasound at our place, close to $1,000. The problem with renal ultrasound, as many of you know, is it's not that accurate with stone size. It's operator dependent and patient dependent, right? If you have a typical Wisconsin unit patient, you can't really do an ultrasound a lot of times. So, and then the KUB, which is sort of the industry standard historically, is about $200. It's cheap, but interestingly, radiation-wise, it matches up, and obviously the regular CT is more. So we did a study, and we have a bigger one coming out, but we've done now almost 400 of these, and basically we're able to find skin to stone distance, Hounsfield density, and volume using this low dose approach, and it gives you 4.1 millisieverts versus 13.4 in a standard low dose CT. KUB is 2 millisieverts per shot. So if you miss, right, and the patient's long or the technician's off, more than 50% of the time we do 2 shots anyway, so that gets you right to 4. So there you have it. I think I missed slide 68 because we put that in. It should be right there. Anyway, I can just explain it. So we just published, a deep learning algorithmic study using CT, so that now it's basically a standard program where rather than doing hand measurements of stone volume over time, when people come in for multiple CTs, the voluming and the volume changes can be just delivered to you as a report. So again, what I'm interested in when I'm surveilling someone for stones typically is their metabolic growth. Because if they're stone-free, we'd probably discharge them. If they have big stones, we'd reoperate on them. And we're able to do that very easily using an algorithm and some technology. So either way, what's hot in surgical procedures? Of course, PCNL, ureteroscopy, and I think at the end of the day, better imaging. What's not are safety wires, in my view, KUBs, and shockwave lithotripsy. And I think, the future is greatest for better imaging. And I think our radiology colleagues are, I think, in a position where they can help us. So I encourage you to work with yours and, try to get better imaging, because I think the idea of annual CT or doing all your studies based on CT is just not practical, at least at our place and many others. Oh, and there's my slide. Sorry, so I went to the back side there, but this is basically saying that this fully automated assessment tool works. So let's move on to finish with non-surgical approaches to kidney stones. So as they say, if the sole goal, you'll see more quotes than you want to tomorrow, but the sole goal of the capman was not to lose his or her ship, then they would never leave it in port. So I think, we have to do our best to look ahead when it comes to stone disease. And, I've always learned that when you're a specialist, you can't be married to a procedure. You have to be married to the disease. Just like every person in this room is a specialist, you realize that it's not all about the procedure. So stone disease, non-surgical approach doesn't sound exciting, but good to stay in the game. This is something we wrote years ago, but looked at sort of the various mechanisms to decrease ureteral contractility. And interestingly, alpha blockers were there on this slide, as with calcium channel blockers, and then even ultimately PD5 inhibitors. So, the concept of altering the ureter, particularly once a stone in it, is certainly relatively new still in the big picture. And this was some work back when I did research, and we identified alpha receptors in both the obstructed and normal human ureter. So alpha blockade should be a reasonable approach for stone passage. And in point of fact, the AUA guideline came out in 2007, and a meta-analysis showed that patients did 30% more of the time pass their stone in the ureter using alpha blockers and steroids, and the panel supported that. This is Steve Jobs. This is the original iPhone. Does anyone have the original iPhone or use it? I'm guessing no, and I wouldn't read this guideline either. So since the guideline, medical expulsive therapy has taken a substantive turn. Probably one of the best journal club articles you can read in stone disease is this Pickard study in The Lancet, where they basically did phone interviews and identified that there was no difference using an alpha blocker in terms of intervention and looking at tamsulosin, nifedipine, or placebo over a 4-week period for a single stone. So right away, this stands right in the face of oodles of information supporting the use of alpha blockade. This Metzer study, which came out of the NIH, I was an associate professor when I was placed on the Data Safety Monitoring Board, and I was a full professor by the time it got done. It took years to just randomize 500 patients. And actually the biggest barrier was getting the CT, because no one was willing to get CT confirmation, although the study group insisted on CT because we had several individuals who were very much in that camp. But ultimately what it found was no difference. So if you went placebo versus tamsulosin, there was no difference in the outcome of stone passage by CT. So it supports SUSPEND and various other trials that show that, at least in the United States, if you're not using steroids, it doesn't make a difference. We did a survey of our stone patients in Stone Clinic and asked them, we gave them in lay terms the findings of the SUSPEND trial, and we asked them if they would take tamsulosin, would they take steroids, and what they said was they wouldn't take it, or at least they were pretty split. They wouldn't want to take steroids. And there was also an area where you could make comments, and the most common comment was patients were surprised this was the best study that urologists could come up with to look at this treatment. So certainly at this point in time, it was not preferred in our view by patients anyway. Well, that's not the end of the story. There are a number of other studies done, and excuse me, this is changing. And if you look at MET for ureteral stones, if you look at all the meta-analyses of the RCTs, there is a benefit for the larger stone, particularly in the distal ureter. So I say to our people today, that's maybe where the sweet spot is. The other thing is all the data says it's 7 days. It's 7 days of tamsulosin. And I don't know about your emergency room, but in ours, they're writing for 30 days because that's how long we'll wait. It's really not necessary. And it's usually the larger distal stone, which makes sense because maybe if you do alter the contractility of the ureter and the stone's already all the way down there and it's bigger, it might fall out of there. But either way, I think it's pretty limited, targeted treatment. So again, at present, I think for something we do all the time, I'm guessing you do, maybe you don't, the outcome is conflicted at best. And again, if we're looking at new technology, new thinking, the cost benefit's at odds, because people do get lightheadedness and so on with the drug. And I think in the world of shared decision making, it's mixed. But if you're going to give it, it's for that 5 millimeter distal stone. And I'd make the case, a lot of the people that are being treated, the best person that's getting the treatment is the urologist because they feel better because they put them on something. But anyway, that's how I see that one. Another important area is alkalinizing the urine. And this is a big part of what you might do if you're doing your metabolic evaluations and treating patients for their stone disease. And if you use Uracid K, it's expensive, it's difficult to take. They're large tablets, and not infrequently the tablet itself is in the stool. And it's just designed as a matrix, because back in the old days, Uracid K used to be polycitra. It's actually like a sand-like texture that you would mix in orange juice. So it's just terrible to do that 3 times a day. So they moved to Uracid K, which was an invention by Mission, but now that's become an expensive drug that's hard to deliver. So Chris Peniston on my team said, just take baking soda, and when dietary sodium is not a major concern, this appears to be a very good approach. In addition, there's a new powder equivalent called litholyte, which is actually a lot better than the old polycitra K, and we've done some studies to identify that either one of these is superior, both in cost and in effectiveness, to the Uracid K product. So I think, first off, you don't have to give everyone Uracid K unless, potentially you're more concerned with citrate. Then I'd use litholyte, but baking soda is a good option, and it's lower cost. So I think you should try to use, these different approaches. And more importantly, I think if you're in medical management, you're helping the patients just because you're seeing them to some degree. And this is a classic opportunity to do this virtual. So almost all our visits in the Stone Clinic today are virtual, which moves us away from the shared appointments that I alluded to earlier. Here's some of the data on it, and basically it shows efficiency with both techniques. Again, the patient's acceptance of litholyte's pretty good, so I think that's a good option for it. So I'll wrap up by talking about quality of life. This is a great quote from Paul Lemke back in the 50s. It is not how well or how frequently a medical service is given, but how closely the result approaches the fundamental objective of prolonging life, relieving distress, restoring function, and preventing disability. Stone disease is a great area for quality of life metrics. It's not a metastatic consideration. You basically, if you die of stone disease, you die of either sepsis or renal failure. And these are things that will produce symptoms. So managing quality of life, I think, is a great area to look at. And back in 2006, I brought this up, that we should have a disease-specific tool to consider this. You can use, as you all know, the SF-36, which is 36 questions, and it's a standard quality of life tool, but it's always better to get a disease-specific tool so you can learn a little bit more. So again, within a year, we began to look and publish in the literature on Wisquall. Mark Litwin, a good friend, helped us begin to learn about quality of life metrics and how to design a survey. And Chris Peniston really did this by doing interviews with 2,000 of my patients, I think, over time, or maybe 200. But ultimately, it was thousands before we got it right. So here's what our ultimate study looked like, and we were able to identify that the Wisquall was more sensitive than the SF-36 in identifying people with lower quality of life and stone disease. So most of the additional questions in the Wisquall are related to urinary symptoms, and symptoms, the rest of it, pain and such, is on the standard SF-36 already. But either way, this was a validated instrument, and it was more sensitive, and we identified, a series of important insights, I think, that are valid. And patients who did worse on the Wisquall generally had decrements in sleep disturbance, nausea frequency, missed time from work. And I think as practitioners in stone disease, you recognize this. And these items are unique to the Wisquall and are not in quality of life survey. So it's one good survey to consider. This was something we presented and published in 2013 in JU. We ultimately created a stone consortium, a quality of life stone consortium with 15 sites, maybe 20 today. And we did longitudinal follow-up data and really validated the facts here that you could follow this by distributing the questionnaire. Ultimately, my hope, and I think it's probably not going to bear fruit, was that we could replace imaging by having a quality of life tool. And what we were looking for were differences in the imaging from how people filled out the questionnaire. And we haven't got there, of course, but it's certainly a very usable adjunct. So what are some of the things that we've identified over the years? And, this consortium is like CV Helper. I think everyone that's in the consortium has 5 or 10 publications. So from it, income correlates with improved WSQOL scores, comorbidities inversely correlate, diabetes and hypertension, of course, which would be stone risk. Advancing age is associated with higher WSQOL scores. Potassium citrate correlates with better scores, as does hydrochlorothiazide or chlorthalidone, which I wasn't necessarily sure of because a lot of people aren't compliant with the drug, but in point of fact, ultimately, this proved to be the case, and probably it's a case that metabolic management has its quote-unquote advantages. More recently, we looked at gender, and actually some of the initial studies clearly showed that females had lower quality of life with stones than males, at least by survey standards. Staghorn stones, non-staghorn stones were the same between PC and L. Asymptomatic stones did not alter QOL, so it's a consideration. Travel distance lowers it. So again, we have a lot of patients come from a distance. Metabolic syndrome, increased stress, and the number of stone events are all logical truths that have certainly borne out, at least using this tool. During COVID, a question we asked is, can we deliver the WSQOL remotely? So can we do it by phone or by mail, or does it have to be in person? And in our analysis, symptomatic patients reported lower QOL by mail as compared to phone or clinic. So I think we don't know. I mean, the short answer is we don't, and we're still trying to figure this out. The other point is, 28 questions. We all get these surveys. I think we sent you one this week if you're a stone person about safety in the operating room. You're just tired of doing 20, 30, 40 question surveys, right? So we tried to create a short form. And to some degree, it was a response to the USAQOL survey, which is at the bottom from Joshi, which is a 16 item quality of life survey from Europe. So we attempted to get this down to 6 best fits. And so we published this just recently. And these were the 6 best questions we could ask, and it appears to be pretty close compared to the 28. So potentially in a MyChart application on your phone before your visit, you can fill out the 6 questions, and we can get this information even more easily than we currently do. So there's a short form approach as well. So basically everyone gets one of these studies when they come see us. So in conclusion, what's hot and what's not for non-surgical stone management? I think precision targets for tamsulosin, alternatives to potassium citrate, and health-related quality of life. I think what's not hot are steroids for stone passage. We don't use it. Uracid K or potassium citrate, again, because it's difficult to use. And an area I didn't get into today because of time is the use of opioids. I mean, these are way down in the use of stone patients, and that alone is a 30-minute lecture, which we don't have time for. But either way, these are what I think are hotter, and I still believe firmly that health-related quality of life in the right disease, is a very valuable piece of the puzzle for us. And I think if we can begin to deliver this effectively remotely, which is something we haven't proven yet, that's another way to monitor our patients without bringing them in and then doing x-rays and such. So anyway, I'll just try to create a summary for you. And basically, my award winners in terms of what's hot in endourology today, I think telehealth or the use of remote care is critical. I also think we have to make strides in imaging, and we have to contain cost and get better information, because ultimately that's still a very good way to measure how our patients are doing in an objective way. The other is HRQOL, but certainly I have not been able to prove that it's as good as imaging. So with that, thank you for your attention. And again, thank you for the kind invitation. I look forward to answering as many questions as you want, and also look forward to having a couple days with all of you, because I know I can learn a lot. So thank you.
Just a housekeeping thing, just to remind people we're here tomorrow, and we start at 7:30 with breakfast, and then this talk start at 8:10. Who wants questions? Don't make me throw it really far, please.
I'm just going to walk to you.
Okay.
I've done this before, and it was a disaster.
Here you go.
Hey, Dr. Nakada, welcome. Thank you. It's an amazing, comprehensive overview, and your achievements and your team, you've touched on all these corners, so congratulations to you. I just want to pick on that access sheath thing that you were talking about with access sheaths, and then pressure. You had that graph with the pressure. Just want to get your thoughts on intrarenal pressure during ureteroscopy and cost. You know, you mentioned cost a lot today, and like the new scopes that are coming out that might measure this and the cost. And we have healthcare leaders here, and we're always looking at the bottom line in the operating room about what we're spending. So I wanted to get your thoughts on that. Thank you.
Sure. So I'll start with the access sheath. You know, again, I think for me, I still like, if I can treat the native ureter in situ without, you know, what I would consider unnecessary dilation, I'd do it. Sheath also has a cost, but it's not expensive. I think it's $100 some odd, depending on which one you use. So you could make case it's not a huge cost. I disagree that it saves time. I think it adds to time. But we use sheaths probably, you know, 10% of the time if the scope doesn't go up. So I think it's a valid instrument, and we carry them. So it's not like we don't use them. And my colleagues may use them more than I do, because we have 3 other fellowship-trained stone urologists. You know, with regards to pressure, yes. I mean, I think pressure is a consideration. I'm aware that there are several companies that have a telescope that can measure pressure and temperature. And I think, you know, we need some data. I need to know what to do with that information. And it's sort of, you know, it begs the question, you know, back in the day when I did renal cancer, you know, we identified all these renal tumors. So, but we didn't really know what to do with a 2-centimeter renal tumor. And, you know, back in the 90s, if you had a 2-centimeter renal tumor, you know, that was coming out, either the whole kidney or part of it. And, you know, today we know that's not necessary. So I think we're still in early days. I'd be interested in your thoughts ultimately, but I think we're early days with both. That being said, with the increased utilization of particularly the TFL, the thulium laser, certainly I've seen a couple of obliterated renal pelvises from outside institutions. We even might have had a stricture we induced, but I've seen multiple strictures using the higher power laser. So it's a concern. And again, I don't know that we know the answers. But part of our randomized trial, what I learned, and you know, we're embarking on a multi-center trial. We've begun randomization, and you know, it's difficult to even know what setting to use on the thulium, because we have 4 other, you know, institutions that have different settings. So I think there's a lot to be learned there, and I think I don't have the answers, and I know you're funded to do some of that work. So I look forward to hearing that. And I think the same happens with pressure. What I can tell you in observing some leaders doing ureteroscopy historically, and when I was a fellow, we used to go, we would hook up the Alton Dean pressured bag, and the nurses had to change it every like 12 minutes, because you could literally, it was like a fire hose if you opened up and this is back at WashU with Ralph Kleiman. So, you know, we had tremendous visualization. But this was 100 millimeters mercury at times. So this is much higher than what I was using with Pathfinder. But, you know, I think also, you know, the tail is in the tape, if you will, in terms of what we actually find. What I do note, you know, and it's not really lecture detail level, but an important point is, my position on stone analysis has changed, in the last 10 years. We published a paper, Sarah Best was the first author in 2008, where we showed that 93% of the time you could predict stone analysis without having the stone analysis based on CT criteria, Hounsfield density, history of the patient, et cetera, et cetera. But if you read that paper again, which I frequently have my residents do, if you read that paper again, where's the 7%, right? And the 7% were struvite stones, because you just couldn't predict the struvite stone patients using the standard algorithm. So it's important to know that. And so why do we talk about it, or why am I bringing it up now? Because I'm convinced that, if you look at patients that get septic, they will typically have a percentage of struvite stone composition. And the reason I think we don't know this well enough is because we don't, match up the dots. So we do the procedures, you get your stone analysis and they get septic, but then 3 weeks later, do you actually look at what the stone analysis was? So I do think that's a consideration. And the other consideration I noted more recently, we presented this at AUA, is how often do you think stone composition changes? And in fact, one of the students from here knew the answer to the question, which is about 25%. So I've gone from trying to eliminate the need for stone analysis to saying every time we do a case, we need a stone analysis, because number one, over a 3-year period, 25% of the time, stone composition may change. Do I care about it if it goes from calcium oxalate monohydrate to dihydrate? Probably not. Do I care if it's calcium phosphate? Yes, right, because you might reconsider alkalinization. But the biggest is if there's struvite in there, I think you do have to seriously, reevaluate, whether you're going to use pressure devices, or maybe you should use a sheath in your case, as you aptly point out, and then even consider using lower settings or a lower power laser to create less thermal energy. I know that was a long answer to a simple question, but that's how I see it.
Thank you, Doctor. Great presentation, terrific overview, and for, a life work of this. My question was about the prescriptions for alkalinization. And yes. I'm from Salt Lake City. I have a lot of patients that don't like medications.
Sure.
What sort of supplements do you recommend, or do you ever recommend the kind of non-prescriptive supplement route? A lot of stone patients don't take any meds. So
yes. So if I get it right, so you're interested if we, and again, it's a team, do we recommend supplements? And the general answer is no. I think the diet or medical nutrition therapy trumps most things in the sense, but if you break it down by category, to me, the place where you might go off script is oxalate, right? Because if you have high urinary oxalate, there are multiple reasons for it. And probiotics, probably can be a last resort or an option. So we would prescribe probiotics in complex oxalate patients. Otherwise, it's pretty standard. It's either dietary change, or it's going to be chlorthalidone. It's going to be, either Uracid K, or citrate-based beverage, or litholyte potentially. But it's pretty simple, and I think Chris Pennison did a beautiful study where it's sort of a behavioral change study, and if you meet her, she wants you to do 12 things differently, and I can't even remember the third, much less the 12th, and that was the genesis for the study. So if you were to ask a patient to make a lifestyle change, particularly for something like stone disease, where they've just had their stone removed so they don't have pain and they know it's not life-threatening and so on, the best you're going to get is 2 changes, right? So if you go with 2 significant changes, what's your number one lifestyle change for any stone? It's increasing your fluid intake, number one. And then probably number 2, it's lowering salt. So that becomes a little problematic with the baking soda example, but those would be your top 2 things you can do. NIH has supported through this PCORI grant looking at fluid approaches, just approaches to fluid change. And I think this can be substantive. And if you look at the history of stone disease in terms of medical management, there are only 3 papers that actually show a difference in stone events. And that would be the paper looking at fluid. That would be the paper looking at thiazides for hypercalciuria, and then the treatment of uric acid stones, with alkalinization. Beyond that, a lot of it is still largely unproven. So it's reasonable to go the dietary route. That's our approach.
You're going to make this the last question. Go ahead.
Hey, Steve.
I've learned if I give long answers, I have to answer fewer questions.
Thank you for that talk. You mentioned several things in there that I want to bring up. One was success criteria for new technology. And you've also talked about PCNL, how it's somewhat limited in its dispersion and dissemination. I'm curious to get your thoughts on the Monarch robot and if you think you see that making an impact and where it may fit in.
Yeah, so great question. For those of you who don't know, the Monarch robot is a robot that really helps guide access, and it's almost like a combo ureteroscopic percutaneous surgery, right? Because the Monarch guides an access in, but you have to have the ureteroscope in to identify the calyx, right? And so, do I think that's great technology? Yes. And truth be told, we're trialing it, so we're very interested in it. And I think that's the way, maybe the future. Either way, I think the struggle ultimately with PCNL is I think even today the interest in it, in terms of the available companies, is not as great as it could be, and a lot of that is a numbers game, right? There's 100 urologists in the United States that do large volume PCNL work. So if you have a new technology, you're going to sell 100, right? Maybe 150 if you're lucky. On the other hand, how many urologists do ureteroscopy? 10,000. So, that's where, I think the focus is, and I think that's a lot of how society's driven, for better or for worse, at least in the United States. And I think ultimately the Monarch is something that will potentially put PCNL in the hands of more people. And so we're hoping that we'll be able to facilitate doing percutaneous procedures with the robot. So I think it is an excellent technology, and I'm fairly sure we'll be using robotic guidance at some point. There have been a couple of robots already, as you well know, for both percutaneous access and for ureteroscopy. So I suspect, that's the future. We just don't know how distant, that future is going to be. The question I thought you'd ask me would be more why we don't do supine PCNL. Do you guys do supine here? PCNL? Okay, so that's great. I mean, we've talked about it, and the good news about having younger colleagues is, who's going to draw that straw. But, at this stage, we're not, I think the number of patients at our place would really benefit is relatively small. And, the learning curve is always something hard to overcome, particularly at a time when OR time is very tight. But that's a cop-out answer for sure. But, you're kind not to ask it. But I think that's, to me, also an evolving area, but it's certainly limited use in the United States. But there are at least 5 places that I think have become facile at doing supine. So that's also a consideration. But short answer is Monarch robot, 100%. I think this is the direction we need to go.